being very important in the comprehensive treatment planning. We've talked before about the combination of therapies enhances efficacy, especially when treating depression and anxiety, how this really fits with the biopsychosocial approach. It addresses comorbidity. We find that integrated care is efficacious, and Jeff, you and I have talked about how that's such a valuable part of school-based health center care. And we also talked last time about there being empirical support for the combination of psychotropic medication with psychotherapy, in that it's been found to usually be superior to either alone for treatment of depression, anxiety, and other conditions. And various sources of support were identified, having to do not only with clinical studies, but what's become standard of care. Of course, the American Academy of Child and Adolescent Psychiatry recommends starting treatment of depression and anxiety with psychotherapy alone, especially for younger children. However, the combination of pharmacotherapy plus psychotherapy has increasingly become first-line effective treatment for adolescent depression and anxiety, especially when severe. And usually it's the severity that drives clinicians to prescribe the psychotropic medication. The medical economics, as well as our busy schedules, often prompt us to prescribe as a way of attempting to treat something as quickly as possible. And that's not to overlook the fact that we really do want to help people feel better, experience less distress, and less severe depression and anxiety whenever we can. By the way, the abbreviations there refer to psychotherapy modes of cognitive behavioral and interpersonal therapies. And it's also important, as pointed out by the American Academy of Child and Adolescent Psychiatry in their policy statement, soon to be yet again revised, that whenever we're prescribing a psychotropic medication, we really need to make sure that psychotherapy is included in the treatment plan. TADS is an important study that we reviewed last time that's really become a big part of the foundation of the current clinical research support for the clinical practice of combining medication with therapy. And in this case, it was fluoxetine with cognitive behavioral therapy, showing the phenomenon mentioned earlier, greater efficacy than either alone. And it's important to point out that this really pertains to the early phases of treatment, acute and the continuation phases, where we're really trying to do something as quickly as we can to be efficacious, especially when the risk for suicidality, perhaps other harmfulness, and consequences of diminished functioning are greatest. Now, the same study has been used to cite the fact that in the longer term aspects of treatment, cognitive behavioral therapy alone showed as much benefit as the combination with an antidepressant. So both phenomena really are true. Combined treatment more efficacious early on, farther out, cognitive behavioral therapy as a form of psychotherapy was shown to actually be superior and have the most sustained benefits. Well, as we launch on to part 2 today to talk about medication selections and other considerations, I'm wondering if that bell that I just heard in our system points to Virginia or anybody else joining us at this time. Virginia, is that you out there? You know, with 3 of us on right now, I welcome as much of your participation. I really want to hear your comments. You know, certainly having Jeff and Hernan here before, I know what you guys have to say is really worth listening to and considering, and I think I'm going to find that to be the case, or we will, with Virginia as well. Virginia, if you're on, I'd want Hernan and Jeff to know that you're in Chinle, Arizona, and you're with Johns Hopkins.
Correct.
And you're a clinical social worker?
Yes.
And a licensed marriage and family therapist?
Yes.
Thanks for joining us, Virginia.
Yes, this is she. I was trying to, can you hear me?
Yes.
Okay. Yes, I am probably about a 30-year veteran at this point in terms of mental health. Moved to Chinle a year and a half ago from the Cleveland Clinic, where I was with the family medicine department and was the behavioral health faculty there for about 12 or 15 years.
Well, welcome, Virginia. Thanks for joining us.
Thank you.
And you're in the company of a couple accomplished pediatricians, one being Jeff Powell, who is in
Jeff,
Shiprock.
Yes.
See, Jeff, how widely you're known.
I know. Virginia, we've crossed on email paths with your Hopkins program together on diabetes, which I love.
Right.
Yeah. I'm an Ohio kid, too, by the way. I grew up in Columbus.
Right, and so I'm glad to have you on, too, because the issues of, particularly, I think, of depression out here in youth is very high.
Yes, indeed.
I ditto that, and Virginia, as Jeff and I have discussed on a number of occasions, and Virginia, I think that today's conference is also an opportunity to find out about some other resources that may be available to you and your colleagues for collaborative behavioral health assessment and treatment.
Good. Thank you.
And I also mentioned another esteemed pediatrician is Hernan, who is in Las Cruces, New Mexico.
Hello, Hernan.
Hello, Virginia. Welcome.
Thank you.
So one of the benefits of having a small audience is that we get to make sure everybody's introduced to each other and that we can, have an opportunity for a conversation about a topic such as selecting medication for use effectively in youth with depression and anxiety. So our main objective this afternoon is going to be to distinguish 6 psychotropic medication classes and select those efficacious for youth depression and anxiety treatment. And that's not to say that all 6 classes have members that would be recommended. Certainly not recommended for first line or perhaps even second line treatment of depression and anxiety in youth. But for one reason or another, all of these medicines have been used at some point in some settings for the treatment of youth with depression, anxiety, and comorbid conditions. Clinical psychopharmacology offers psychotropic medication classes that definitely have therapeutic benefit for pediatric depression and anxiety in the primary care and school-based health center settings. So here's a listing of the 6 classes plus others. We have the antidepressants, and we'll go through the SSRIs, the SSNRIs, Bupropion, others, as well as augmentation of those agents. Mood stabilizers, lithium, and anticonvulsants. And the fact that mood stabilizing properties are also found in the newer atypical antipsychotic medications. Benzodiazepines have been an older approach to treating anxiety and has often been referred to as anxiolytics. The alpha-2 agonists, great medications for impulsivity, sometimes have been used for anxiety as well. Psychostimulants are probably known most about by pediatricians and pediatric subspecialists in various disciplines. And then there are some others, such as atomoxetine or Strattera, could actually be placed in an antidepressant and anti-anxiety category. We'll talk about that, as well as diphenhydramine, hopefully to no surprise. Well, embarking on the SSRI antidepressants, of course, let's begin with the SSRIs because they are by far the most commonly prescribed antidepressants. And it's interesting that they're prescribed more by pediatricians even and other primary care providers than they are by child and adolescent psychiatrists and psychiatrists in general. I think the various agents are well known. In part 1, we talked about how only 2 of them, fluoxetine, known as Prozac, and escitalopram, known as Lexapro, actually have FDA approval for the treatment of depression in youth. They have the FDA approval for depression and anxiety treatment in adults. And some of them have more specific FDA indications, such as PTSD in adults. We talked last time about various extrapolations of clinical efficacy as well as safety that have permitted these agents to be prescribed in an off-label fashion for depressed and anxious youth, such as the prescription of sertraline, which actually has the FDA indication, that is approval for, prescription to children who have OCD, but not other anxiety disorders and depressive disorders. They've been therefore found to be safe in youth, and therefore it gives us a lot of confidence that they'll be safe in youth who have other anxiety disorders as well as depressive disorders. These agents work by blocking the reuptake of serotonin in the central nervous system. Their main uses are for both depression and anxiety, and they really have become the first choice for the treatment of depression associated with substantial anxiety, whether it be coexisting depression and anxiety disorders, or when anxiety is a prominent feature in a subsyndromal way for a depressive disorder. There are some other uses for SSRIs as well. Bulimia nervosa, premenstrual dysphoric disorder, and for addressing impulsivity as a target symptom, such as in youth who have autistic spectrum conditions, also known as the pervasive developmental disorders. Next in line and very close in some of their properties are the SSNRIs, which we can consider as being like an SSRI that also includes the reuptake inhibition of norepinephrine presynaptically. They're also effective for depression and anxiety disorders. Venlafaxine, known as Effexor, is probably the most popular, while Pristiq, marketed for desvenlafaxine, has become very popular. I just mentioned here that sustained hypertension has been a concern with these conditions, but by no means does a history of hypertension contraindicate a prescription for venlafaxine. There are a couple other SSRIs that are being prescribed more recently for depression and anxiety in youth, and they are duloxetine or Cymbalta, as well as mirtazapine and Remeron. Sharing from my clinical practice in the pediatric clinic at UNM and in some other venues, I've been finding that duloxetine and mirtazapine have been prescribed by my pediatric psychiatrist colleagues for youth much more in just the last couple years, whereas venlafaxine was being prescribed even more often going back to the latter 90s. I also want to mention that Remeron is quite sedating, so it's prescribed at bedtime, sometimes reported to help with youth who are having severe nightmares. Duloxetine has the ability to reduce pain and other somatic discomforts that are associated with depression. We usually think of adults as having those depressive features, but when we consider how many depressed youth present with headaches and GI upset, it's really worth considering duloxetine for them as well. Bupropion, known as Wellbutrin, sometimes has been referred to as an atypical antidepressant, perhaps viewing it nowadays because it doesn't have a clinically significant action on serotonin. So it's here in parentheses. From a research perspective, it does have some action on serotonin systems, but not in a clinically meaningful way. Whereas it is clinically significant for norepinephrine more so than for dopamine. It's been found to be especially effective for individuals who have more of the melancholic features of depression, such as much lower energy and motivation, so-called high inertia, little positive reactivity to the good things in life, and yet those are features that we often see in older youth, adolescents, as they age, rather than in younger children. There's been some clinical support, research support, if you will, for the use of bupropion in the treatment of ADHD, theoretically supported by its dopamine activity. And for those who have coexisting ADHD and depression, that is, most individuals could really benefit from this medicine. It's also been really helpful for youth who don't have much anxiety and are overweight and present with a rather dysthymic picture. These individuals have benefited from bupropion as well. A word about anxiety and bupropion. I listed low anxiety because it's a less effective medication for bupropion. And yet, if somebody presents with mild anxiety that is clearly associated with their depression, one needn't stay away from bupropion just because it doesn't have the anti-anxiety efficacy of the SSRIs and the SSNRIs. That doesn't mean we shouldn't consider using it for other youth that I just described. It also has a side effect of increasing anxiety, but again, that doesn't contraindicate the use of medication in individuals who have low-level anxiety. Now, there's some other antidepressants that are here in a more time-honored fashion, and I think I'm...
Hey, Dan.
Yes.
Hey, this is Jeff up in Shiprock. Hey, I'm getting called away. I'm going to leave things rolling on the speakerphone, and I might be able to rejoin in a few minutes, okay?
We can only hope, Jeff, and you're welcome to
I know,
hop back
right?
on.
I love it so far. Thank you. I've already learned.
Thank you for being here, Jeff.
I've learned at least 5 things already. So hopefully I'll be...
You're on a roll, Jeff.
Thanks, Dan.
Okay.
Bye, guys.
Tricyclics are used much less these days, and I was starting to admit that I'm dating myself a bit by having knowledge of them. These medications were the main antidepressants when I began my training. They were preceded in their usage by the MAOIs, the monoamine inhibitors, which are used the least often these days. They're used selected for very refractory forms of depression, and more so with adults than youth, but sometimes in youth. One has to eat a tyramine-free diet to avoid a hypertensive crisis when taking these medicines. And that is something that has made their use much less convenient. Tricyclics have had serious cardiovascular concerns, especially when taken in overdose. And I mentioned risks earlier that are much greater in early stages of severe depression, such as a major depressive episode. Well, the risk of overdose on medications was even greater with the tricyclic antidepressants because they have a risk of creating fatal arrhythmias in individuals who over-ingest them. Ironically, the prescribed appropriate doses of tricyclic antidepressants are actually a therapeutic anti-arrhythmic. Okay, so we would sometimes choose them for adults who had a particular kind of arrhythmia. I think it was a type 1A. It's been a while since I had to do that kind of prescribing. Trazodone is a serotonergic agent that is really sedating at the very high doses that are used for antidepressant effects, but at even low doses, they are very effective for sleep in youth. And we really don't use sleeping medications per se very much for youth nowadays. Usually trazodone is tried, and so is Benadryl. I want to mention augmentation agents. Since we just talked about trazodone, trazodone is effective for sleep. Other serotonergic medicines we've talked about are helpful for depression and anxiety. Usually SSRIs and SSNRIs are prescribed during the daytime, at least initially, because they can be at least a little bit activating. The addition of trazodone at night for insomnia to another serotonergic agent taken in the morning can have a synergistic effect, not only with regard to the time of med administration, but their mechanisms of action are complementary. So trazodone is a serotonergic agonist, while the serotonergic medicines I've mentioned so far, trazodone excluded, are serotonin antagonists. Okay, so different mechanisms. So thereby there can be an augmentation. Likewise, Buspar, that was marketed for anxiety, relatively not nearly as potent as the SSRIs for anxiety. Different mechanism of action. Sometimes when the SSRI doesn't seem to be quite as effective enough, the addition of Buspar, also taken during the day, can augment the SSRI, or vice versa. Synergistic effects, different mechanisms of action. Tryptophan, by the way, acts by basically thermodynamic laws as much as they can be followed in vivo, to synthesize more serotonin from its precursor amino acid. This can be another augmentation strategy. More serotonin around for the agent, the serotonergic agent, to act on. Lastly, I'll mention a derivative of folate, L-methylfolate, marketed as Deplin, can help individuals who have a genetic tendency to not transport enough folate across their blood-brain barrier. Folate being so important in monoamine neurotransmitter synthesis that by adding a form of folate that can be readily transported across the blood-brain barrier can allow more neurotransmitter synthesis and thereby greater effectiveness of these agents. Also, one can speculate that if individuals don't get enough active folate in their central nervous system to synthesize enough neurotransmitters, perhaps there is a bit of a neurotransmitter deficiency there. So perhaps it would be effective to try adding L-methylfolate first and see if an individual's depression and or anxiety improves. I'm just speculating about that. Stahl did not write that in 2007. The maker of this medication, PAM Labs in Louisiana, does not make such a claim. I've asked them if they have any empirical support for that, and they said that they don't. Nevertheless, I find it worth ongoing consideration. Other things to consider have to do with what are some of the other psychotropic medications that are used for more severe depression and other mood disorders. Well, there are the lithium preparations. They're used for mania as well as depression. They're anticonvulsants. And there definitely is some antidepressant efficacy, not only for lithium, but for lamotrigine. So for individuals who have very refractory depression, very serious depression, not responding to any of the usual agents, these agents are sometimes added on, okay? That could be considered an augmentation. It also can be considered a dual agent approach. With all of these medicines, there really needs to be such close clinical monitoring. For matters such as lamotrigine, has a risk of causing rash and the severe syndrome, including rash of Stevens-Johnson syndrome. Valproate preparations such as valproic acid, Depakote, can cause problems with the bone marrow, that is blood formation, hepatotoxicity, liver, as well as pancreatitis. So laboratory monitoring becomes very important with these agents as well. There are also, as I mentioned earlier, mood stabilizing properties in the atypical antipsychotics, and they're being prescribed more and more. That is, those under that newer category of the so-called atypicals, okay? They're different than the older neuroleptics. They tend to cause fewer side effects overall, whereas the older neuroleptics work primarily by way of dopamine blockade as a source of their antipsychotic action. The newer atypicals also act on serotonin systems in the brain and therefore have some of their antidepressant and mood stabilizing qualities. The atypicals also have been used to target particular behaviors such as aggression, self-injury, and lability. And one of the advantages of the atypicals is that they clearly have a better side effect profile. The older neuroleptics tend to cause major side effects all the time, whereas the atypicals do it variably. Nevertheless, some of the neurologic side effects of the antipsychotics, such as Parkinsonism, are seen with the use of atypicals, including the newest one, aripiprazole, or also known as Abilify. Well, which psychotropic medications from that initial list have been prescribed to youth before their depression and/or anxiety are identified? In other words, what medications are youth presenting with in the primary care clinic before we've determined that they have depression and/or anxiety? Well, there are the anxiolytics, the benzodiazepines, if you will. They've been used for a long, long time since Leo Steinbach developed Valium for Eli Lilly in the 70s. Nowadays, they're really reserved for short-term treatment of acute, severe anxiety, agitation. Sometimes somebody will be given a one-time dose of lorazepam or Ativan, for example. Also used for insomnia, and there's some other ones such as Restoril that's used for insomnia, much more in adults. Because nowadays the SSRIs are really preferable for ongoing treatment of anxiety, and certainly preferable compared to the benzodiazepines. There also are the alpha-2 agonists, very helpful in individuals who have ADHD, where the psychostimulant alone is not quite doing it and they continue to be really impulsive. These medicines are very helpful for impulsive behaviors and impulsive aggression in conditions that do not include ADHD. Do not include ADHD comorbidity, that is. Conditions such as conduct disorder. I mentioned earlier the pervasive developmental disorders, referred now to as the autistic spectrum disorders. Often there is impulsivity that can be treated as a target behavior with these agents. I tend to choose guanfacine over clonidine for daytime use especially, due to its longer duration, plus more favorable side effect profile. It has a long enough duration of action for it to be used easily as a before and after school medicine taken at home, rather than to depend upon school dispensing by a nurse or school health aide. Clonidine, being more sedating, can be very effective at bedtime. I wouldn't choose it as a sleeping agent in and of itself, but for the highly impulsive and hyperactive individual who can't get to sleep, clonidine can be really useful. Sedation and orthostatic hypotension are among the most common and concerning side effects. Now, I was just thinking about the psychostimulants because when I mentioned that clonidine can be a very effective medicine to give at bedtime for the very impulsive individual, and that I wouldn't prescribe it alone, but that it's sedating enough that for those who need it for other clinical reasons, it can be very effective to give it at night. But I wouldn't recommend adding clonidine because of a youth who has trouble sleeping while prescribed psychostimulants and didn't have insomnia prior to being treated with psychostimulants. We know these are medicines that are used primarily for all forms of ADHD, especially the combined type and the hyperactive impulsive subtype. They work primarily by way of dopamine and norepinephrine systems. But how they do this, the degrees to which they do this, are not fully understood. There is a consensus that reuptake inhibition is involved, as is release of neurotransmitters. But there are various reports from various studies in textbooks, some of which are in your references for this talk, that give rather conflicting information about which system is acted on more than the other or exclusively. But most of these sources have come to the conclusion that dopamine and norepinephrine are both involved. Well, I think we're all familiar with the methylphenidate as well as the amphetamine preparations. The trend has become to the manufacturer, distribution, and prescription of the agents that are effective for a whole day or a majority of a day. So for methylphenidate, much more use of Concerta, all-day use, Metadate, all-day use, so these are longer-acting agents. There also are longer-acting agents of dextroamphetamine, even though some of them have not shown such consistent efficacy that it varies over the course of a day, such as the Ritalin SR preparation. The amphetamine salts in Adderall are also available in a long-acting form taken in the morning, lasts throughout the school day. That's referred to as Adderall XR. The caveat that I want to bring up with regard to today's topic is that there are a number of individuals, number of students, number of youth who have been misdiagnosed as having ADHD, and their features are really attributable to their depression and or anxiety. And the prescription of a psychostimulant can actually worsen their depression as well as their anxiety. So that needs to be a concern when we are considering medications that have been prescribed before there's been an assessment of a use, depression, and or anxiety. Well, I mentioned a couple other medicines. Atomoxetine or Strattera is an SNRI. So that is not akin to the SSNRI. It's not a selective serotonin and norepinephrine inhibitor. It's a selective norepinephrine inhibitor. It reportedly has the greatest efficacy in the ADHD world, that is, for the inattentive subtype, where there is an appreciable impulsivity and hyperactivity. When all of the features of ADHD subtypes are together, it's the combined type. That's what the C is in your handout. And there's really been shown to be less efficacy for youth who have that form of ADHD. Potentially this medicine could show efficacy for the treatment of depression and anxiety, and therefore in that initial list it was mentioning that atomoxetine could fall into a different category with time. Diphenhydramine or Benadryl, I mentioned earlier, is commonly used for insomnia in youth. Again, in addition to trazodone and Benadryl, by and large, are used most often for insomnia in youth. And the sleep agents that are taken by adults generally are not prescribed. It's sometimes used for anxiety on an as-needed use. So if we are somewhere out in public and we encounter somebody who's having an acute stress reaction or a severe panic attack that is persisting, the administration of some diphenhydramine could really help that individual. It definitely has a sleepy side effect, so its use is not as effective while a youth is in school. but it has a very safe margin of safety. The therapeutic index is quite high. Okay. I have found diphenhydramine to be useful, by the way, when receiving referrals of a preschooler who is out of control and the family or foster family wants some help with getting this kid back under control. I think it's important to touch on some dosing guidelines for youth psychotropic medications. The prescription of these medicines in youth. We want to start low and go slow. It's something that pediatric prescribing has in common with geriatric prescribing. I'd have to say, however, that starting low and going slow has really been my standard of care with adults as well. Because we know it really fits with how, if untoward effects are going to occur, they generally occur early. So why not start with a low dose of the medicine? If a severe untoward effect develops, they're taking a low dose. It's easy to stop the medicine altogether or to give it some time and see if it improves before doing something different. And the eventual dosage of these agents may be as high for adults as they would be for youth, due to youth having such a high metabolic rate. Well, I'd like to ask if there are any questions, thoughts, concerns, comments, beliefs, even protests.
One question I have, this is Virginia, is the transition from one medication to the other. The rule of thumb, 3-4 years ago was to titrate down slowly and then make the transition once the medication had been cleared. Is that still the thought?
That is certainly true for some medication classes and some of the representative meds within a class.
Okay.
However, it really does vary from class of medication to another class of medicine. And it can differ from agent to agent. A lot having to do with what the pharmacokinetic properties of the medicines are. So, for example, if somebody was taking the SSRI paroxetine, which is Paxil, not in the sustained release form, but just regular Paxil, it has among the shortest half-lives of any of the SSRIs. So if somebody was taking Paxil, they could be instructed to just stop taking it if it's another SSRI that's being started. So within that group, Paxil could be stopped and Zoloft started the next day. Took your last dose of Paxil this morning, start your sertraline tomorrow. We're already going to start low and go slow, so we're going to start at half of our initial target dose of 50 milligrams. We're going to start at 25 of sertraline. Okay? I think that really makes sense. On the other hand, fluoxetine, or Prozac, has a very long half-life. So it will actually automatically taper, however. So we don't even have to instruct somebody to taper the dosing. It will do it automatically. So as its dose as the amount of fluoxetine comes down in the body with time, it would be like telling somebody to cut their Paxil dose in half for 3 days and then cut it in half again 3 days later. It just will do that automatically. And meanwhile, somebody could start taking sertraline. So the instructions would be the same, and it would seem like the medicine is not being titrated, or tapered, but in both cases, they're given the same instruction. Does that make sense?
Yes, yes.
And that's really
Actually,
true also. Yes, Hernan?
Yeah, you mean you start the sertraline right away, the next day?
That's right. So in both cases, when changing from fluoxetine to sertraline or paroxetine to sertraline, the instruction would be the same. Stop them both today. Okay, stop the fluoxetine today, stop the paroxetine today. Start the sertraline tomorrow, but it's going to be for somewhat different reasons.
Now, let me see if I understand. I'm sorry, if I understand this correctly. That would mean that the patient then is going to have on board some fluoxetine, some Prozac.
That's right.
Salt for a few days.
Yeah, and how long that's going to be could vary. For example, I may choose to start somebody on sertraline at 25 milligrams and keep it at 25 milligrams if we're transitioning from fluoxetine, because the fluoxetine is going to stay around in the body for a longer time than would paroxetine or Paxil. With that medicine, once we stop the Paxil and we're starting the Zoloft, we could go up on the dose of Zoloft even more quickly.
What is the importance of not interrupting the treatment abruptly?
Well, for one thing, with the SSRI antidepressants, there can be a withdrawal. I'm not going to call it a reaction as much as there can be a syndrome, a withdrawal syndrome, whereby the person develops symptoms that are similar to the flu.
Okay. Thank you.
Yes. Now, there also may be the decision, there are two things here. One is, if the medicine is being stopped, okay, if we're deciding to stop the medicine, we're going to want to taper any of these medicines to prevent the person from developing the unpleasant physical effects that can come with abrupt discontinuation. Okay? So abrupt discontinuation causing withdrawal symptoms, unpleasant effects, is the answer to Hernan's question. But there's also the situation where there is the ongoing need for having an efficacious medicine for the treatment of anxiety and or depression. And if we find that fluoxetine or paroxetine initially don't work, we're going to be interested in trying another one, and it may be sertraline. I go back
Dan,
to... Yes.
Dan, are you still on? This is Jenny again, Virginia.
Yes.
Do you find that most primary care physicians explain this as they're prescribing? That youth understand that the abrupt change is not good? It's one thing to forget it for a day, but not to just abruptly stop it.
You know, I think that is an aspect that most prescribers do mention.
Okay, good.
Hernan and I were having a conversation about the amount of information that can be helpful for youth and others involved to hear about during the informed consent process. And there's so much information that it can be hard to do that within a quick primary care clinic visit. But I think that the item you just asked about usually is included by most clinicians, by most providers, prescribers.
Virginia, if I could make a suggestion, you should ask Dan to make accessible to you the previous talk he gave.
Okay.
He goes rather extensively over the prescribing process.
Okay.
And you might find some answers there to some other questions in relationship with that very thing.
Okay, thank you.
And Virginia, that is available on our website calendar at envision.nm.org, which is a website that is on the email that you received.
Right. EnvisionNM.org. Okay.
And if you go to the calendar and click on March 6th, the handout for Part 1 is there. And by the way, shortly after today's conference, the handout for today's presentation will be there.
Okay. Thank you.
And if I may, this is Kevin Worling, your IT support. We also have the video from last month.
Or audio?
Well, it's audio and slide set.
Got it.
So if you wanted to watch that and listen to that, that's available the same website, but go to the videos page.
Oh.
Okay.
And scroll down to the TPICC videos section.
It is really worth it, let me tell you. It's one of the best explanations I've ever heard on pharmacology prescriptions.
Okay.
Well, thank you, Hernan, for sharing that with Virginia. And your comments were just recorded. They're going to be broadcasts in advertisement of this series.
Very
good.
Just kidding. Thank you, Kevin, for mentioning the video. I had forgotten to include that in the resources.
Relatively new thing, so.
That's really great that we have that now. So speaking of resources, here are some tools. Earlier, the American Academy of Child and Adolescent Psychiatry's policy statement was mentioned. There's a link to it. By the way, it's in the process of being updated, but it makes some good points. It's a one-pager. The Guidelines for Adolescent Depression in Primary Care is a great resource. And here are some publications, a couple of them again from the Child Psychiatry Academy, textbook of clinical psychopharmacology, as well as a textbook of child and adolescent psychiatry. Cases is really the emphasis of our TPICC. And going with that, the main reason I don't post the handouts for the presentation before our conference, because I really want to keep reminding people that we not only welcome your case submissions, but we really encourage it. We have the form for a brief summary of your cases that's downloadable from our TPICC website, the portion under Telepsychiatry. Encourage you to take a look at that. Think of a case you have. Even if you wanted to create a composite of many youth that you've seen over the years and their various attributes for purposes of discussion, I think that would be great. I also mentioned, Virginia, at the outset, other resources that you'd become familiar with today. Telepsychiatry Consultation is available for New Mexico pediatric providers who do not have a psychiatrist on their team. We really emphasize the collaborative approaches to behavioral health care, encouraging behavioral health providers to collaborate with pediatric health care providers to enhance capacity for behavioral health care in the primary care settings throughout New Mexico. Contact information is here. We recommend the scheduling through Clancy. We have other ways of doing that, but we really want to make sure that we get you on the schedule. And while the 4 hours each week are listed on this slide, being subject to change and having some latitude within my schedule, if these times don't work, we can accommodate you at another time. Also, I wanted to mention that, of course, Kevin knows that you're both still on, so you're on the roll call.
And Jeff Powell did not join us again, did you?
Well, I'm back. I was keeping an eye on the slides.
Okay. Jeff,
is there a way to get a copy of the rest of the talk?
Yes, it will be posted on our Envision calendar, envision.nm.org. Go to today's date, click there. I think if not by the end of today, by the end of tomorrow, this week, it will be there.
Does it have the audio?
The audio will be posted a little bit behind on those, so it'll probably be the beginning of next week. And you go to, we were just talking with Virginia about this, that go to the videos page towards the bottom of our website, and go down to the PICC section, and you'll see it there. You'll see last month's, and then as soon as I can get it up there, this will be up right above that one.
All right, and that's the Echo webpage?
That is our webpage, which is the envisionnm.org, standing for Envision New Mexico.
Sure, yeah. Great. But yeah, I certainly enjoyed the first part, Dan. Thank you.
Oh, I appreciate your comment, Jeff. I think if it's providing that much worthwhile information for you, it really makes it worthwhile to continue doing this.
Yeah, absolutely. Found it to be really in-depth. There's a lot of new material there for me regarding some of the different classes of meds, Personally, I feel like I've had like step 1 and 2, knowledge for a long time, but not more of the in-depth work.
Well, and there's more and more coming out, and I'll look forward to continue to update the series. And I'm sure that we'll revisit psychopharmacotherapy as we do another go-around in the coming year. And maybe adding on more current information to what we've been doing.
Yep, perfect. When's your next case consultation, Dan?
I'm glad you asked that, because I was just going to announce that Wednesday, May 1st, will be the next PICC session. That first Wednesday of the month at the noon hour.
Yeah.
If you're finding that your colleagues are saying that's just really not a time that works for them, if there's another noon hour during the month that works better for our colleagues and yet works for you, I would be willing to look at making a change. Yeah.
All right.
Okay.
I can ask around.
I know
noon hours are the best.
Go ahead. Noon hours.
But the noon hour is the best.
I think so.
I agree. This is Virginia. The noon hour is best for me, anyway. And I will begin to check around in terms of some of the colleagues here.
Honestly, Dan, our pediatricians, they're usually, kind of in a panic to finish clinic by noon.
Right.
And locally, the IHS is probably one of the only facilities in healthcare business in the world where they shut down half a day a week. So they shut down Wednesday afternoon, essentially, so they can do meetings. But they're never free at noon. Just so you know.
Do you think that Wednesdays could be does that make Wednesdays a good time for IHS because they're closed down in the afternoon? And
the bummer thing about IHS in general is that each place has a different set of operating control teams. And so every facility will have like a different time of the week where they do their administrative meetings.
So for example,
that's going to be it.
At Shiprock, do they tend to close on Wednesday afternoons?
Yep.
Okay.
And then
how about
Chinley's, Chinley is Thursday mornings.
Oh, really?
Yeah, so each one is different.
Yeah, gotcha.
Well, I'm going to have to sign off. This is Virginia. Thank you, Dan, very, very much. This has been very helpful. And
really
I look forward to the next one. Yes.
And if you
have a good day.
have preferences for a topic for next time, let me know. Thank you for joining us, Virginia.
Okay, thank you.
And Jeff
Bye-bye.
and Hernan, it's really a pleasure having you.
Yes. Thanks so much, you guys.
Take care.
Bye, Dan.
Okay, bye-bye.